Ever had a mystery red eye that keeps coming back? That's a common herpes story. In part 2, Dr. Mika Moy explains how herpes infections recur, what triggers them, how they affect the cornea over time, and why treating the wrong condition can delay healing and increase scarring.
Welcome back to part 2 of my conversation with Dr. Mika Moy. In this episode, Dr. Moy explains current treatments for herpes simplex virus. We talk about herpes simplex bllepheritis around the eye, the eyelids, and you'd mentioned it a little bit before. Talk about it. Is it always primary or can it be secondary?
A primary infection of HSV may not include any vesicles. It may not those are called vesicles, that sort of little, it's almost like a little rash that you get, but it's usually quite small, quite focal. You can have a primary infection show up that way, but that would be more common in an infant that doesn't have a robust immune system. There are some adults that don't have a robust immune system, either because they have a disease like HIV, for example, maybe undiagnosed. HIV is so manageable these days with the proper treatment, but everyone probably has HIV before they're diagnosed unknowingly. And so those folks have a depressed immune system. There are certain diseases that would make your immune system depressed as well. And there are certain treatments for diseases that purposefully depress your immune system, like for autoimmune diseases, for example, where your own immune system is attacking your own body. A lot of treatments for those help control your symptoms and your disease by depressing your immune system. So if someone were to get their primary infection when their immune system was either not well developed because they're a baby or depressed, then that would be something that would happen. And then reactivations, oftentimes with reactivations, patients will get them most commonly on the same side of the face because of how the nerve anatomy is and where that virus is hiding. But often in the same similar location. So if their last episode of herpes blepheritis was on their lower lid, oftentimes their reactivations are on their lower lid as well. Sometimes I'll leave standing orders for a patient because oftentimes the patient will have a symptom before the vesicles show up. And oftentimes they will describe it as it starts off as almost an itch or a burn or a tingle, and then their skin will turn red, and then they'll see the vesicles come. And the sooner we start the antiviral, the more likely we are to not have an episode that's very painful or severe. And so in a very experienced patient who has a lot of recurrent disease episodes, I oftentimes will just, arm them with the medicine that we know works, which is an oral antiviral, so that they can start treatment when they have that sensation before I would even be able to diagnose them because I wouldn't see the typical signs.
And for our students listening out there, what would the dose be? Now, if you have something like this, you go see your doctor, but this is to help our students that may be listening.
When it comes to herpes simplex, for me, it depends if it's on your skin or in your eye. Textbooks will tell you the dose is the same if it's on your skin or in your eye. I have a different opinion, and a lot of doctors are forming different opinions about the dosing that would be more appropriate for in your eye versus on your skin. But we tend to call these simplex doses and zoster doses. Zoster doses tend to be about double a simplex dose. So if we're talking about acyclovir was the first herpetic antiviral drug that was available. It was made by Merck, I think, back in the 80s, long time ago. And the dose for simplex blepheritis would be 400 milligrams 5 times a day. That's a weird dose. Usually most drugs are like twice a day, 3 times a day, 4 times a day, but this is a 5 times a day drug. And that is considered a simplex dose. If you have a patient who instead of simplex has zoster, then you would double that dose. So it would be 800 5 times a day.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. And how about if we use Fanvare or Valtrex?
So Fanvare and Valtrex came later. All of those drugs are now available generic. And so it used to be that I really preferred acyclovir because it was the cheapest. And a lot of times with optometry, we're seeing patients who may not have health insurance, or they might have a health insurance that I can't access for them. And so they're coming to me for my expertise, but maybe they're having trouble getting into their own system. And so I would often pick whatever was cheapest. Well, acyclovir is still cheapest, but Famvir and valacyclovir, they're more bioavailable. And all that means, it doesn't mean they work better. It means that you don't have to take as much of them to get the same effect. So Famvir would be like 500 twice a day, or you could do 253 times a day. And then valacyclovir would be 500 twice a day for a simplex dose.
Now let's talk about the number one cause of blindness for infections, herpes simplex keratitis. Tell us about that. And that could be tricky. I've seen a ton of this, and people will come in and they could have one dot of SPK or loss of tissue on the front of the eye called the cornea. But the pain is out of proportion a little bit, and something doesn't smell right. Tell us about those people.
So herpes simplex can also affect your cornea. Your cornea is the most innervated tissue in your body. So there's a nerve ending just about for every cell that's in the surface layer, the epithelium of your cornea. So when you even have a small issue in your cornea, it can hurt very badly. And pain, like I was saying before, is one of the main symptoms that I use to differentiate between sort of the more significant bad diseases and then the more sort of run-of-the-mill big three diseases. So when herpes simplex is advanced in the cornea, it creates a lesion which looks like what we call a dendrite. It sort of looks like branching, so it's somewhat linear, and then it kind of branches off, has these little arms and legs coming out of it. It's very easy to diagnose herpes simplex when you've cooked it long enough to have a dendrite. But if the diagnosis is delayed until the patient has a dendrite, boy, that poor patient has been suffering for a little while because it's very painful, even if it's a little dot. And now this thing is millimeters long, poor, poor patient. So astute clinicians will have a suspicion, as Dr. Gelb does, when the patient is much earlier in the course of their disease. So initially, herpes does not look like a dendrite. It actually looks like, and it can be just one little epithelial defect. Now, we call that SPK, or superficial punctate keratitis. It's an indication usually that a cell is missing from that corneal mosaic. But if you look at very high magnification at that one little defect, you might notice that it looks a little different than a typical SPK. Typical SPKs is like a cell is missing, but if you look at this and it looks what we call stellate, it almost has little pointy, like a snowflake, little pointy edges to it. It should pick up fluorescein staining, that yellow dye that we use. It might, but it might not, pick up a different type of stain called rose bengal, which is like a magenta pink color. But another thing to look for is around that little defect, you can see corneal swelling or edema. It's really hard to see. You have to set up your biomicroscope properly because the cornea is meant to be clear, and you're looking for something that's not quite clear. It's barely on the foggy side of clear. So it's a contrast sensitivity task. Can you tell slightly foggy, like the slightest fog you've ever seen compared to clear? And what I notice is around those tiny defects, you have tons more edema than you would expect. So this tiny little defect is microns big, but you might see edema that's 2 to 3 millimeters surrounding it. To me, that is very suspicious of HSV. And so I will typically treat patients quite early in the course, because if I can catch it early and I can give them the proper treatment early, they won't have to suffer so much with a painful lesion that's growing. And there's no evidence, this is anecdotal from me, but when the superficial layer of cells is affected in HSV, we call that the corneal epithelium, that doesn't scar. The problem is that if that disease infiltrates and goes down deeper into the cornea to the area that's called the stroma, it disrupts the cells there and that can scar. And the only way to fix that, if it's in just the wrong place and it's right on the part of the cornea that you use to see, the only way to fix that is some sort of corneal transplant. So I think it makes sense that if I treat it sooner, I'm less likely to have that happen.
Now, I've also noticed that it's deeper, that epithelial defect is, you see epithelial defects all the time, what we call SPK, and they're superficial, from dry eye, incomplete blink, maybe rubbing their eye from a contact lens. But when it's herpes, it just looks different. It's just deeper. And like you said, there's that little swelling around it. It just looks different. And a lot of times, as eye doctors, we're not 100% sure, but we're going to treat them for herpes because we know that if we don't, it could turn to become a catastrophic case. And that's something that we don't want to have happen. And we talked before by putting steroids, sometimes if they go to the walk-in clinics or they go online and they have an online appointment with somebody that's not an eye doctor, right, and they wind up giving them a steroid combination eye drop, because a lot of times patients will feel better. You give them a steroid, they feel better. But you're taking a big risk because it's pouring gasoline on the fire.
Absolutely. Absolutely. And what'll end up happening is they will, because they feel better, they'll continue using the drop, and it will only be when a few days will go by, and now usually they've cooked a really good dendrite. Sometimes these can even look placoid. So it's not confined to a skinny line. Sometimes it's almost geographic. And they'll come in and they'll say, well, now my vision's kind of funny. Or I had a patient once who came in and said, I see this funny thing. It looks whitish on, well, he didn't call it his cornea. He said, over the colored part of my eye. Yes. And because it's been treated with a steroid, it doesn't look like a classic textbook picture of what HSV keratitis. It might look like a dendrite, but these can also look more geographic. And so it's problematic. And in my experience, after someone's been treated with a steroid on a herpetic infection, they don't respond to an antiviral as well as those who have not had inappropriate steroid treatment.
I remember seeing people that we had these non-healing ulcers in the VA when I was doing my training, and that was many years ago. But because they were on steroids for so long, it was very difficult to get these defects to heal the front of the cornea. And these people were pretty miserable. They first of all they couldn't see well; it affected their vision, and they were very uncomfortable. And we're trying to heal this thing back in the 80s, where we don't have the technology like we have today.
Oh yeah, yeah, I can imagine.
So let's talk about recurrence. About 40% of these herpetic lesions will recur. Talk to me about that and what should we do about it? And when should we do prevention? Like when they have they have it the first time, should we put them on preventive medicine for the rest of their life? Should we wait for them to have it the second time? Do we know? Is it just by feel? How do we do this?
Yeah, so that's a great question. I almost never will put someone on a preventative dose or a maintenance dose of an antiviral after their initial presentation to me. The exceptions would be someone who has a compromised immune system where they're more likely to get a recurrence. But for the average person who has a perfectly fine immune system, they just got their HSV infection in their eye, they could go years to decades without another episode. They might even go their whole life without another episode. So I wait until it becomes problematic. So if a patient has recurrence within a year, for example, I consider that problematic. And then we can talk about, is there a certain trigger? Can you identify something that happened? Certainly, if your immune system is busy trying to fight off something else, that's when herpes can bloom in the eye or wherever you have it. Again, the HEAD study, which is the herpetic eye disease study, it's been around for quite a while now. They actually looked at triggers, and they determined that triggers weren't real. And let me kind of explain to you what they did to help you understand that. So people had noticed, hey, uh, Herpes outbreaks seem to be associated with stress, with illness, with sunlight exposure, with the menstrual cycle. Like there were all these things that seemed to have outbreaks. So they got a bunch of people who had uh, repetitive herpes outbreaks, and they asked them to keep a journal and keep track of all the things that people thought may cause reactivation. And what they found was at initial blush, oh yeah, look at this. Stress seems to play a part, and contact lens wear was another one, and being sick, all these things, they seem to be real. But then what they looked at was, okay, who's keeping their journal? What they asked the participants to do was, okay, at X time every day, you give me on a scale of 1 to 10, like all these triggers, like how is your stress? Are you menstruating? Did you wear your contacts today? And they were supposed to do it every day. And what happened was, of course, people forgot, they didn't do it. Then they would have an outbreak and they'd be like, uh-oh, I better go fill out my journal. And when they had people who went retrospectively, oh, all the triggers showed up. But when they had people who actually filled them out correctly, it wasn't statistically significant anymore. Now, having said that, I work on a college campus. I must tell you that I notice outbreaks closer to finals, which happens to be right about now. Now, is this scientific? No. Might I have recall bias? Absolutely. Um, but it would be interesting if we might do a little bit of a study to sort of see retrospectively, we could do a chart review and just see, hey, when are we diagnosing these and what's the age group and were they students or were they not students? So it's interesting. So triggers are not supposedly a thing, but it's something to think about. It sort of makes sense with the immune system and everything, that certain triggers would depress the immune system to a certain extent.
Well, you always have these people that, I certainly have friends that they go out in the sun and then they get an ulcer on their lip, a herpetic infection on their lip, and they feel 100% every time I go out in the sun, I'm going to get this. So
I
sometimes,
believe it. It's hard not to believe it.
right, right. So let me ask you about, obviously, you mentioned pain. This is painful. Talk to me about you mentioned the dendrite. How do we tell the difference between dendrite from a herpetic infection, herpes simplex, versus pseudodendrite, whether it's from zoster or from a healing abrasion, or somebody got a thread in their eye? How do we tell the difference?
Yeah, so that can be tricky. A dendrite simply describes the shape, right? So there are other things that can look like dendrites that really aren't dendrites. So, for example, a healing abrasion um, is from a trauma. So I was playing basketball and my friend poked my eye with their finger, and now it's the next day, my eye really hurts, and I've gone to see the eye doctor. So now I'm looking at an abrasion that's healing up, and corneal abrasions heal really fast, right? So it might look linear to me, and now I've got to figure out, is this from the we have this wonderful history of I had a trauma yesterday, but guess what? Trauma is also one of the triggers that could cause HSV. So I've got to determine, what does it look more like a dendrite versus not. Other diseases can also cause things that look like dendrite. So we mentioned zoster. Zoster has things that we all refer to as a pseudodendrite. And in the biz, when you say pseudodendrite to an eye doctor, they assume that you mean zoster. But a pseudodendrite just means something that looks like a dendrite that you've determined is not HSV. So when you look at pseudodendrites versus HSV dendrites, so zoster, pseudodendrites versus simplex, there's a couple of hints that will help you. Zoster dendrites tend to look more feathery. They tend to look more fragile, more lacy. They bifurcate, they branch off more often, and they have this very lacy, feathery look to them, versus simplex looks a lot beefier and stronger. The arms that are coming out are thicker. They have terminal end bulbs on them, which means that where the arm ends, there's like a little bit of a larger area, like there's a bulb at the end of that arm. Pseudodendrites tend to happen more on the edges of the cornea, and HSV dendrites can happen wherever they want to. But you're also going to take the history of the patient into consideration. So, zoster a pseudodendrite, more than likely, although they don't have to, but the patient probably has had a rash, that typical shingles rash around their eye before their cornea was affected. But what's interesting about zoster is the cornea can be affected months after the shingles rash has gone. So sometimes I think people can forget that and they're like, whoa, this looks like a dendrite, and they might start thinking about simplex, or maybe the patient hasn't told them I had shingles almost a year ago now. And then you look and you say, oh, no, no, this is a pseudodendrite. Now, luckily, the treatment's somewhat similar, especially if you espouse a zoster dose or a higher dose of antivirals when you're treating herpes simplex on the eye like I do. For eye doctors out there, give it a go, give it a try, see what you think. I think when you see how much better a zoster dose works against simplex and how much faster your patient feels better, you might convince yourself it's worth a try. I think a lot of times what optometrists do is they're very comfortable with doing very high doses of topical medicines, right? So an antibiotic, I'm treating a bacterial corneal ulcer, I'm going to prescribe that every hour. Nobody thinks twice about that. But as soon as it comes to an oral medicine, sometimes they're like, oh, I better go buy the book. Here's what I would suggest. If the patient's sitting in your chair, you've diagnosed them with simplex, but let's say they had zoster, would you hesitate to give them that dose? If the answer is no, then give it a try. Antivirals are very well tolerated. There are very few side effects because their mechanism of action, they actually work on the virus itself. And the human body doesn't have that same thing. So there are very few side effects. It doesn't affect human cells. And so it's safe. It's been deemed safe to use in pregnancy even. So there are a couple of things to be aware of. For example, in elderly, the older I get, the more I think elderly is a much different age than me, but I'm approaching elderly. In the elderly, high doses of antivirals can cause central nervous system issues like hallucinations, agitation, things like that. But what's nice is if you look at the different antivirals that are currently available to us, if you have an older patient, then I think it's Famvir that's better. That's right. It is Famvir that's better. It has fewer of those side effects. The only other side effect that if you look online, it'll say GI upset. Well, it turns out that acyclovir is made with lactose. And so if you have a patient who's lactose intolerant, do not give them acyclovir. You're going to give them a problem. But Famvir and Valtrex don't have lactose in them. So those are some very minor things that you can do to sort of make your patient more comfortable. But the bottom line is these medicines are quite safe and effective. So please don't shy away from giving a higher dose for simplex. You'll just be amazed at how much better your patient gets and how fast they get better.
Yeah, and that's really the new philosophy is to give the Zoster dose for simplex now, because why not? The medicines are very safe. There are very few side effects. Like you said, it's category B for pregnancy. It's very safe in pregnancy. We haven't talked about the drops for
Mm.
herpes simplex. Viroptic, which has been around forever, is now Zergan. Talk about drops. Should you be on a drop and the pills, or the pills are just all you need is the antiviral pills, or should you be on both just to be safe? So tell me about Viroptic. When I was doing my residency, there was no Zergan. We were using Viroptic and an old drug that I'm sure you heard of Vira A, but they don't make anymore that we used to use. But now, unfortunately, they don't make it because it was an ointment, and it used to make the doctors feel better anyway to use it, and we used to see people get better. But tell us about Viroptic and Zergan and whether or not to use it with orals or instead of oral antivirals.
Yeah, I miss Vira A.
Mhm.
Vira A actually has a different mechanism of action than all the other antivirals. So I'm sad that it's gone. I think it's still available maybe in Canada and Europe. So if if your listeners live in Canada or Europe, you might still be able to get Vira A, and just know that all the Americans are jealous. So all of the antivirals that are available commercially now all have the same mechanism of action. So what that means is sometimes doctors will do both. They'll do a simplex dose orally, and then they'll add a topical. All you're doing there is you're making your patient's life more difficult because now they have to do two things. But what you're doing is what you can do just by giving them the zoster dose. You're creating a higher level of pharmaceutical in the eye. What's cool about all of the oral medicines is they come to therapeutic doses not only in the tears, but in the aqueous. So simplex can actually affect all the layers of the cornea, including the endothelium. Now, I've only seen one case in my career, oh no, I've seen two, of herpes simplex endotheliitis. It's gnarly. It's kind of cool because the endothelium stops working, so the cornea gets all kinds of swollen, right? Because the endothelium's job is to pump out the water from the cornea, and it's sick and sad and doesn't do that anymore. But oral meds, I get therapeutic doses in the aqueous, takes care of that. So by using a pill and a drop, if you just use the zoster dose, you'll have the same therapeutic effect, but it might actually be a little bit better because a drop goes in the eye, it hopefully absorbs into the tissue, but you're blinking it out, it's going down your nasolacrimal duct, and you don't perhaps get as good of a concentration for as long of a period of time. So personally, I prefer oral medicines over topical. However, there are, optometry is a legislated profession. There's some states where maybe it's not available to those optometrists, so they have to use the topicals. Or perhaps your patient can't swallow pills. There's a reason why they can't be on the medicine. So one thing to be sure of with antivirals is that they're metabolized and excreted in the kidneys. So if you have a patient who has significant kidney disease, and you can look up, you want to do a creatinine level, and you can look up, there's equations to figure out, can your patient's kidneys handle an oral antiviral? But if you want to be safe and they have kidney disease, then you need to use a topical. And I've been in that situation before too. Topicals work great. It's just that they can be a lot more expensive. So ganciclovir, that was a huge, when that came out, that was wonderful because Viroptic, the only drop we had up until that point, can be very irritating to the eye because of the preservative. And you had to use it so many times a day, right? It was like every 2 hours, don't exceed 9 times a day. And that was mostly because of the preservative. Ganciclovir is more like a gel. It comes in a tube. It's not available generic yet, so it can be pricey depending on the patient's insurance. These are things we have to consider in the United States. But it works really, really well, and it's not irritating to the cornea. Way back when, with Pseudodendrites and Zoster, the thought was there was no active virus in the cornea. And so when you saw a pseudodendrite, your patient should be on the oral meds, and then you would just use artificial tears. Recently, well, not really recently, but now that we can kind of do PCR and we can see, actually there is virus there, especially in immune compromised patients, sometimes it is helpful to have the zoster dose of the oral med and add a topical med. And these are usually for special cases, for patients who have chronic disease, they just can't seem to kick the zoster in their eyes, or they have an immune system problem. But in standard everyday practice, I probably wouldn't add the topical unless I saw that I needed to at a follow-up. I wouldn't do that immediately at first presentation.
How long do you, with your patients, you keep them treated for? Is it 1 week, 2 weeks, 10 days? What do you think?
It's so interesting, right? It seems like everything with oral meds, it's either 7 days or 10 days. That's sort of how it works. To be honest, I usually write it for 10 days because why not? And I had shingles myself like 10, 12 years ago. And I remember, I diagnosed myself. I had the prodrome, so I felt really ill. And then all of a sudden I looked in the mirror one day and I went, whoa. And of course I had ophthalmicus because I'm an eye doctor. Of course I did. And so I see this rash in my eyebrow. I call my resident on call. And I said, hey, I need you to call in a prescription for me. I have zoster in my eye. And God bless her, she said, tell me the case. Now, She's my resident. She's supposed to do what I say. But
Right.
she's also a doctor with integrity. So I actually have a picture. The only reason why I have a picture of me with my zoster rash is because my resident would not call in a prescription for me until I sent her a photo. So I texted her the photo. She goes, I concur with your assessment. And then she called in the prescription for me. But from my own experience, when I was done with my meds, I still was having symptoms. And that's pretty typical with zoster, right? And I really wished I had more. Now, the Z study just came out. The zoster eye disease study just came out this past year. And what's interesting is they had trouble they wanted to recruit close to 800 patients. They only ended up recruiting like 500. And they had two problems. One was, I'm guessing, was the pandemic, because that's kind of when they were recruiting patients. So I'm guessing that gave them some trouble. But the other problem that they had was cornea specialists had heard about this treatment that wasn't sort of in the textbooks. And they tried it and liked it so much that they all were doing it. And so it was hard to recruit patients, because when you recruit patients, it was placebo controlled. So your patient might get the treatment arm, but they might get the placebo arm. And so that was what gave them a little bit of trouble, interestingly enough. But what Zeds has shown us is that it might be beneficial to put someone on a maintenance dose for a year. So they looked at 1,000 milligrams of valacyclovir versus placebo, and they wanted to know, if I put my patient on 1,000 for a year, are they better off? And it turns out what they found was it did reduce eye complications and pain. There was less iritis or inflammation in the eye, keratitis, or what we've been talking about, inflammation on the front surface of the eye, at 12 months and 18 months, and post-herpetic neuralgia, which is something that happens to people where the infection is gone, but they keep having pain moving forward. Post-herpetic neuralgia rates decreased as well. And so now, in hindsight, when I got my case of shingles in my 40s, I would have advocated that that's what I should be given, because of these results. And so from now moving forward with my patients, that's what I'm going to do for my patients who have zoster, is to put them on a maintenance dose for a year afterwards.
Now, if we go, going back to simplex, corneal sensitivity or desensitivity, how important is that to test for that?
So uh, one of the things that's, I think, tricky for eye doctors all have to be detectives to a certain extent, because there's a lot of eye diseases where there's no one definitive test I can give you to decide, do you have it or do you not? There's so many examples. Like, we have so many tests for glaucoma, but there's not one where it's like, this will tell me yes or no. You have to look at the entire picture. So one of the pictures or one of the items that you can look at for herpetic eye disease is whether or not someone's corneal sensitivity has been reduced. So it turns out, these diseases affect the nerves. And how do we test corneal sensitivity? Well, there are people who like using cotton wisps. There are people who like using dental floss. I'm a dental floss gal. What do you like?
Cotton wisp, juice.
I think I like dental floss because I'm in academia, and so like you can actually you can measure how long it is. It's like an isthenometer, which is what you would use in research. You need to be careful, people in the listening audience. Do not use mint flavored dental floss. You have to use unflavored dental floss. Um, anyway, it turns out that corneal sensitivity goes down. Your cornea, like I said before, has lots of nerve endings in it. And these nerve endings are important not only for corneal health, but also for things like reflex, right? So your eyes are very sensitive so that you have a blink reflex to keep things from flying into your eyes. For each episode of HSV that you have, your corneal sensitivity will go down, down, down. Usually, HSV keratitis, simplex keratitis, will affect one side. There are people who can get it bilaterally, but it typically is only on one side. So you have sort of like a control eye. So you can very gently test corneal sensitivity by introducing a cotton wisp to the surface or a piece of dental floss to the surface, and just very quickly and see if the patient feels it. And then you can do it on the other side, and you'll notice a significant difference, especially if this eye has suffered herpetic eye disease several times. Now, it's it's not a very useful bit of information, I find, for a first episode because corneal sensitivity will be the same. So the hardest episode of HSV keratitis to diagnose is the first episode because your patient subsequently will come in and oftentimes they say, I have this funny feeling in my eye and I'm worried it's that herpes thing again. And then you'll look and you'll see signs. So oftentimes the history will clue you in as to what's going on. Now, every once in a while, corneal sensitivity will be the thing that saves the day. I find this especially in older patients who maybe they're not as good historians, or maybe they're getting a touch of dementia. They can't remember what's happened to their eyes. So many things have happened to them at that point. They don't remember shingles that they had in their 40s, like me. That's young to get shingles, by the way. And so sometimes if you're suspecting it or you're suspecting another thing is happening and you need to know, does this patient have a history of herpetic disease? Corneal sensitivity can save the day. But if you're looking at staining, like we were talking about before on the cornea, and you see one little ditty dot with some edema around it, you're like, well, let me do corneal sensitivity to see if that helps me determine that this is actually herpes. In that instance, that's likely a first episode. The corneal sensitivity will likely be the same.
And as the corneal sensitivity decreases, but the patient starts getting better, do you notice the corneal sensitivity start to improve?
You mean on a first episode or like a subsequent episode?
Like a second or third episode.
So, I rarely take corneal sensitivity nowadays because I don't really need it, but I would imagine the answer to that is no, because you can see evidence that suggests that second episode, like if this is normal, then the first episode at the end of it, we're down a little bit, second episode, third episode. So I don't think there's recovery, but I'm not aware of a study that would have looked at that specifically, like middle of disease course after inflammation is gone. Not sure.
And I have to ask you this question for our students that are listening. Rose Bengal versus Lissamine green.
One is pink and one is green. Okay.
It's going to ruin the clothes more.
Yeah. So, if I were a dry eye doctor, which I am, that's not my area of expertise or specialty. We have a dry eye clinic here, and so I'm very happily send all my patients to to that clinic so that they can have those eye doctors who actually specialize in dry eye disease. But they will tell you that Lissamine green is so much better because even though those two things test for the same thing, Rose Bengal stings, and the more you have a positive test, the more things that stain on the front surface of your eye, the more it hurts. Lissamine green doesn't, but here's the problem with both, and more so with Lissamine green. You can get false negatives unless you really put a lot of the dye in the eye. And Lissamine green, they come on these strips. You have to wet the end of the strip with some saline. There are people who want to scratch it first to try to get more of that into the drop that you're now putting into the patient's eye. It's difficult to get enough Lissamine green into the eye with just a strip. It's possible, but it's hard. The other thing is Lissamine green wasn't a thing when I was growing up in eye doctor school. And so I am much more familiar with, and therefore I am much more comfortable with Rose Bengal. And so I prefer that. Now, my students sometimes think I'm mean because I won't anesthetize the patient before I put it in their eye. And that's because the anesthetic alone can cause a positive test. So I tell the patient this might sting. And then you've got to put quite a lot in their eyes. And I can tell by the patient's reaction if they had a sting. And then I usually say, hurry, or we're going to have to do it again. Get into my slit lamp so I can look at you. But by having the patient notice a sting, you know it's a positive test. You just have to sort of see whereabouts it is. And the last piece of advice I'm going to give to our students who are listening is just because something stains with Lissamine green or Rose Bengal does not mean it's herpetic. Lots of things stain with both of those drugs, or not drugs, dyes. And so you need to, a lot of times students will be like, the only time I stain someone with Rose Bengal is when I think they might have herpetic disease. You need to know what it looks like. So the next time you have a bacterial ulcer, go ahead and stain that. Then you can anesthetize the patient. Go ahead and stain that so you can see what that looks like. When you stain HSV with Rose Bengal, even if you have a dendrite, unless it's a very late dendrite, it doesn't stain super strongly. You will see it maybe only go up the spine. It's kind of light. So how it stains, just because it's positive doesn't mean they have herpetic disease. How it stains is also important. And as you were talking about before with the stellate lesions, you might have one, you might have lots. And sometimes when you stain it and it is HSV that's causing that, only one or two of them will pick up stain and the rest won't. That's still all HSV in there. So you need to make friends with your vital dyes, and just know what different things look like when you stain them.
I want to talk about a patient who comes in and their cornea is swollen. Uh, the stroma of the cornea, so the middle part of the cornea, for the people listening, is swollen, and nobody knows what it is. And what we usually would say back at the VA in my day is, we don't know what it is, and the cornea is swollen, it's probably herpes. So let's talk about that and stromal herpes simplex virus.
So stromal HSV, it's something like about 25% of people with recurrent epithelial disease will go on to stromal. Stromal's the one that scars. Stromal's the one that will rob you of your vision. Stromal, well, temporary. If you have access to good care, you can have a transplant, and restore your vision. But stromal is the one that will scar and cause decreased acuity. The problem with stromal disease is that the antivirals don't get to where they need to go. So we talked about how oral antivirals come to therapeutic doses in the aqueous and they come to therapeutic doses in the tears. The problem is they can't pass through Bowman's layer from the front or Decimase from the back. So they can't get into the stroma, which is the middle, right? And so you can be treating your patient with antivirals, trying to get the cause of the inflammation to go away, and you can't. So interestingly, we've talked so much about how don't put a steroid on HSV. Well, it turns out stromal is the exception to that rule. Why? Well, the problem with stromal disease is that your body's going nuts with inflammation trying to kill this thing. And your body sometimes is trying to do a good job and it messes up something else as it's trying to be a good soldier. So what it's doing is so your cornea and your sclera, right? The white part of your eye and the clear part in front are very similar, except the sclera is opaque because the cells aren't arranged very symmetrically and organized, okay? In your cornea, the reason why it's clear is those cells are laid down very meticulously, very regimentedly, if that's a word. When you have inflammation, what happens is those cells, as they're healing, aren't that beautiful geometry anymore. And so the front part of your eye will turn white like the sclera is, and you can imagine you can't see through that. So we have to calm the inflammation down. I know how to do that. I put a steroid on it. All right, didn't you just tell me that the only way this virus is going to go away, since the medicine can't get there, is for your own immune system to take care of it, and now you're turning that off? Well, yes and no. I need it to calm down. I need it to calm down, but I need it to not completely shut down. So I'm going to pick my dose pretty carefully. Most people will start with Pred Forte, which is sort of everyone's go-to medium to strong strength steroid. And most people will start with like a 4 times a day sort of a regimen, see where we're at. And then as soon as I see it get off the visual axis or start to calm down, then I'm going to back off. I can't back off. I have to taper it. I'm going to have to back out slowly. So I'm going to go to 3 times a day. I'm going to watch that patient pretty carefully and kind of try to get them off that steroid carefully, but efficiently. Now, should I put an antiviral in the eye when I'm treating patients with a steroid? Most doctors will do that, even though it's not getting to where it needs to go, but I need to make sure that virus doesn't get any bright ideas and go somewhere else. So if it's in the stroma now and I'm putting a steroid on it, I don't want it to jump to the epithelium. And so most doctors will also put the patient on an antiviral. There used to be this rule about 1 drop for 1 drop. So if you were using a topical antiviral, for every drop of steroid, you put a drop of antiviral. If you're going to use an oral, then you probably would use more of a maintenance dose of the oral. So you wouldn't even use a simplex dose. You might even be under that. But that's doctor's prerogative, whichever the doctor feels most comfortable with.
Very interesting. We always would cover them with an antiviral. We treat them with steroids. We cover them back in the day with Viroptic
Yep.
and Vira A, and we would always cover them. And many of them would do pretty good, and most of them will recover and get better. But those are very tricky, and the diagnosis could be tricky because you always got to be thinking when you don't know what it is, it could be herpes.
Yes, absolutely.
So let's talk about a really bad one, necrotizing. Tell us about that.
Necrotizing, I will send to a cornea specialist so fast, but this is one where multiple layers of the cornea are involved, and you can actually, if it gets out of control, you can actually have a really bad outcome. So I will typically, I often will send my stromal cases to a cornea specialist as well. And that's not because I feel like I can't treat it. It's more so because if the patient has a bad outcome and they do lose vision, if I were the patient, I would want to know that I was in the top tier specialist care. And while my specialty area, I'm considered an expert in anterior segment disease, I am really a primary care optometrist. I cover all parts of the eye. So for stromal disease, because the outcome can be poor, especially if I see it on the visual axis, I will send that out. Necrotizing, forget about it. I'm going to send that out to make sure that that patient is under a specialist care. Necrotizing is pretty rare. And so because it's as rare as it is, what's my experience with it? Not much. What's the cornea specialist experience? Much more than mine, because everybody's referring to that person. I happen to live in an urban area. San Francisco is right across the bay. I have access to a lot of specialists. If you are in a more rural area where you can't be as flippant as me about a referral because your patient would have to drive 5 hours to get somewhere and then, for all their follow-ups and stuff, you might consider sending that to have it looked at first and then co-managing with that doctor so your patient has better access to you. There are lots more optometrists around than ophthalmologists and then subsets of ophthalmologists, cornea specialists. So I have really good working relationships with my cornea people, my retina people, to make sure that we can co-manage and take care of our patients together the best that we can.
That's a wrap for part two with Dr. Mika Moy. In part three, Dr. Moy reveals current treatments for shingles that affect the eye. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight one day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.